today we're going to do musculoskeletal system, and I'm going to start out by talking about diagnostic procedures and tests, and then we'll talk about some disorders, and then we're going to talk about a couple of procedures. Okay, so remember, I'm not going to be going over a lot of the A&P or pathophysiology, so you need to review that, as well as some things that you were taught in the first semester. Walking with aids, like with crutches and with walkers, that kind of stuff you need to review. How to transfer a patient who has a musculoskeletal injury, preventing problems associated with bed rest or poor mobility. So you need to make sure that you review all that and think about all that, along with normal post-op care and prevention. So when we talk about diagnostic procedures, we of course are going to talk about x-rays, scopes. Now remember, scopes are invasive means of direct visualization of an area, whether it's an endoscope or an arthroscope. You put that part in front of it and it changes what you're looking at, but a scope's a scope, which is a direct visualization with a camera. Then we're also going to look at nuclear scans for bone density, which are DEXA scans, and then nerve conduction and muscle activity studies, which are EMGs. Remember to check your Gould's Patho for overviews of some of the diagnostic testing. There's some really good information in the one of the appendices. Also, you need to make sure that you read your Pellico textbook and also look at your ATI review module. There's some good information in there about diagnostic testing for musculoskeletal system. You need to understand why the test is being done, the indications. That's a lot of times what the patient is coming in complaining of, or if they've had some type of injury, those are the indications. You also need to understand about patient preparation and knowledge they need to have, patient care during and after the test, and what the test results mean. All right. So x-rays are the most commonly performed diagnostic procedure in the musculoskeletal system because they can see breaks in the bone. Bone shows up very well in x-rays. Okay, you can see some soft tissue surrounding the area, but it's not as well visualized as bones are. Okay, so it can be diagnostic. X-rays can be agnostic, such as for fractures, or it can be screening as a first step in testing for other problems, and we'll talk more about that when we get to some of the other testing. What are the indications? Injury, pain, deformity, loss of function. All those can be indications of why you would get an x-ray. If you've been in a car accident a lot of time, and you say that you have pain in your arm, they'll x-ray it just to rule out a fracture. Okay, patient preparation. Of course, you're concerned about pregnancy. People who are pregnant shouldn't have x-rays, or if they're not having x-rays done of their abdominal region, you can cover them up with a lead shield. They actually have these lead aprons and shields that you can put on people. Radiation exposure isn't that high. The way that they measure radiation exposure is they look at the kind of x-ray that somebody's having, and then they compare it to the amount of radiation they're exposed to in normal everyday life. And like a barium swallow or a GI series has the same amount of radiation that you would get in 6 months of real life. So that's a fairly high radiation exposure. But a chest x-ray, that's like the amount of radiation that you're exposed to in real life in 10 seconds or something like that. The exposure to radiation isn't that high. Of course, you also have to look at if somebody has multiple traumas and they're getting multiple x-rays a day on multiple parts of their body, then they have a fairly high exposure to radiation, and that may need to be monitored. The number of times and the amount of exposure in a condensed period that could be problematic. Now, if you happen to be assisting a patient with an x-ray, positioning or something like that, you should always protect yourselves by wearing the lead apron. It should have something that goes around your neck too to prevent your thyroid from exposure to radiation. Most x-rays don't provide patient prep. They may need to remove clothing with metal or jewelry. Belt buckles are really bad for showing up on x-rays. You may also be required to assist the patient with positioning, and this can be painful for a patient because they want multiple views of the potential damaged area. Sometimes a patient needs to stand to get a good chest x-ray, or they may need to lay down or sit or rotate their limb in a specific way. and that can be painful. So you need to be cognizant of that and be around to help with positioning and also to provide comfort. Other type of radiology studies, such as CAT scan or MRIs, may be used to diagnose other problems, such as bone cancers, infections, arthritis, and ligament or tendon problems. All right, so arthroscopy is when they want to visualize inside a joint, and this is any joint. They can do this. They can do an arthroscopy in any joint large enough for the instrumentation to get into. So they visualize the surfaces of the joints. They can look at the meniscus. They can look at tendons and ligaments. They can look to see if there's stuff floating around in there that can be removed that might be causing pain or problems with function. Indications for arthroscopy are pain, injury, or functional issues. Okay, this arthroscopy can also be used as a therapeutic procedure where they go in and they clean up torn meniscus, or they trim off tendons that are shredded and stuff like that. They can go in there and do that. This is usually done on an outpatient basis with local or regional anesthesia. Now, patients who have arthroscopy, depending on the area, they can do a nerve block, so they don't have to actually put the patient out, but they will get sedation. Several small incisions are used depending on the joint and what exactly they're doing in there. And this is so they can put in the instruments, the visualization and the fluid, and they can put in little scalpels or rotos to take care of stuff if they're actually doing a therapeutic procedure. Most of the time, the incisions don't require sutures. They're usually glued shut, or maybe they use steri-strips on them. Now, one of the things you need to think about is their scopes are done on an outpatient basis, and they're done in an outpatient center. They're not done in the hospital. They're done in usually freestanding procedures or a facility within the hospital. Patients will present about a week to 10 days before their procedure and get a pre-op done. Pre-op includes they'll see the nurse who will get a list of their medications, they'll get labs drawn, they'll get an EKG if they need it. The nurse will do a pre-assessment kind of thing, and then they'll be seen by anesthesia as well. And they also get a lot of pre-procedure education related to the procedure and post-procedure care. So you need to know that is usually the standard. Okay, unless somebody gets injured and they come in through the emergency room and do it, they have a lot of stuff done pre-procedure at the outpatient. Now, when they come into the outpatient area, and if you're doing the intake on it, you need to check their chart for consent. You need to check their chart to make sure all the labs are drawn and the pre-procedure assessment was done. And then you also need to do your own assessment of the patient. You need to check and make sure they've not taken any medicines that they shouldn't have, like medicines that can cause increased bleeding, medications that could affect renal function or interact with anesthesia, that kind of things. You just need to make sure. That's why you have to do an assessment. I'm not saying that you have to say, oh my gosh, they took gobbledygook medicine and now they can't get this gobbledygook anesthesia. You just need to find out what medications they've taken, when's the last time they ate, and if they're having any signs and symptoms of infection, acute infection, or anything like that. Okay, so that's what you do pre-procedure. They'll also get an IV started, get put on a monitor, all that kind of stuff. So post-procedure care is usually in the PACU and the post-anesthesia care unit. And that includes things that you may have seen in interventional radiology or endo this semester. Assessing the patient for recovery and complications such as bleeding, pain, return of sensation. What's the use of the limb, affected limb? You need to be checking not just the area of the procedure, but distal to it for neurovascular checks and make sure that they still have blood flow and sensation distal to the area of the procedure. It's also a time to reinforce a patient teaching that was initiated pre-procedure. This is when you're talking to the patient's family member or whoever is there to help them. They get ice and elevate the area for 24 hours. If you look over here on the right side, this is a handy-dandy little recirculating ice pack that's been developed. Sometimes you'll have like a little igloo cooler that's like the one pictured here. Sometimes You'll just have a regular igloo cooler that'll hold like a 6-pack or something like that. But ice water's in there and it flows through the pack that's attached with Velcro to the joint that's being affected. And you can do this at the shoulder, at the elbow, the knee, the foot. These packs come in different configurations so they can be used on different areas of the body. So ice and elevate for 24 hours. They need to be taught about pain medications, how to use their splint or sling, how to do dressing changes. A lot of times the dressings are limited to Band-Aids or 2x2s, activity restrictions, and also to monitor for complications related to infection or neurovascular compromise. Again, they need to focus on the area where the procedure took place. Like if it's the knee, they need to check their knee for infection and inflammation and stuff. But they also need to know to check distally to make sure that they're not having any problems distal to the procedure site. So teach them about color, temperature, pain, and sensation that they need to monitor. And you also, of course, need to talk to them about when they should notify their provider. If they're having increasing pain, that's not a good thing. Of course, they should have some more pain sensation once their nerve block or the anesthesia wears off, the local anesthesia wears off, but they shouldn't have increased pain 24, 48 hours after the procedure. That's usually indicative of a problem. Pain should be going down, not increasing. Also looking at erythema and edema, and then other manifestations of infection such as a fever, tenderness, redness, pussy colored drainage, opening of the incision sites, that kind of stuff. So they need to notify the provider if that occurs. Now, nuclear scans are similar to what we do angiographies with iodine, or when you're looking at the thyroid gland using iodine, radioactive iodine isotopes, is very similar to that, but gallium and thallium are very well absorbed by inflammation in the bones. And they have a low risk profile related to allergies. So there's not the same risk of allergies as there is with iodine. Iodine is really good for soft tissue, not so good for bones. Okay, so indications of this. Now, one of the things you got to think about with nuclear scans are not the first line diagnostic procedure. These are usually to follow up other diagnostics such as x-rays or CAT scans that they need to follow up to determine the extent of the disease process, or if nothing showed up on the regular x-rays or the CAT scan, to maybe see some very subtle changes like a hairline fracture. Because what the gallium and the thallium scans do is the radioactive isotopes are taken up by areas of inflammation within the bone. So even with a hairline fracture, there's going to be an increased inflammation in that area, and the bone scans, nuclear bone scans, are very sensitive. They can see very small inflammatory changes. So that's why it's good for hairline fractures or stress fractures. Okay, also for arthritis, osteomyelitis, osteoporosis, and cancer, they can tell the extent of the problems. With cancer, they can tell if there's bone metastases, and a lot of times they'll do whole body scans to see the extent of the metastasis to the bones. Also, if they've done diagnostics, if somebody comes in and they have pain, and they've done diagnostics on it and they can't figure out what's causing the pain, they may do a bone scan for that. It can also be used, gallium and thallium can also be used to diagnose brain, liver, and breast disease where calcification is a problem. All right, the procedure is, again, it's usually an outpatient, and the patient comes in and they're injected with a radioactive isotope of gallium or thallium 2 to 3 hours before scanning, 4 to 6 hours. So 2 to 6 hours before scanning, they have to be injected. Then the scan can actually take 30 to 60 minutes depending on what they're scanning. And the scanner for nuclear scans looks very similar to an open CAT scan, where the patient is kind of sandwiched between a table and the scanner over them, and there's not a lot of space between the patient and the scanner that's above them. So if your patient has some problems with claustrophobia. This is something that you want to know so that you can treat them for that. So the scan usually lasts 30 to 60 minutes and can be repeated at 24, 48 and 72 hours to determine how much uptake there is. And what they do is they do the scans, and once it starts to wash out or the hot spots decrease in intensity, then they'll stop doing the scans. All right, so if you look at these scans, A and B, I believe, are the same person. I don't think C is the same person as A and B. But if you look at A and B, you can tell in the first scan that there's some uptake in those darker spots. But if you look at B, they really stand out. And look down there at B at the right foot. Now the right foot, you can see that there's hot spots in picture A in the second and third and fifth toes. But you don't really see that hot spot there in the ankle. And while it kind of looks like the fourth toe may be hot in the left foot in picture A, you can really tell there's some inflammation going on in the left foot in the second, third, and fourth toes in B. Same thing kind of goes for the hands in A. If you look at that right wrist in the top picture, you can't see that there's a hot spot there, but if you look in the picture in B, that's really very noticeable that there's a hot spot there in that left wrist, in the right wrist, sorry. All right, but then if you look at C, this is a whole body scan, and one of the reasons I don't think it's the same person is if you look at the foot down there by the C, then that's not the same foot that's in A and B. That's a different foot, that's the other foot. The other thing I look at in this picture in C is if you look at the pelvic area, that's not a lot of joints there, and there shouldn't be a lot of inflammation there. I think that this is more indicative of a cancer, metastases. Also look at the cervical and upper thoracic spine, and then you can see that there's a lot of hot spots there. So this to me is more, I think this is probably a scan for bone cancer metastases, or metastases to the bone. So that's just what they look like. I wanted you to see what they look like. So your job is to explain the procedure and assess for allergies in pregnancy and breastfeeding. Like I said, there's a low risk for allergic reactions to the gallium and thallium, but it could still happen. So you need to make sure that they don't have any allergies. And we don't do radioactive scans or scans with radioisotopes on people who are pregnant or who are breastfeeding. Because the scan can take a while, the patient needs to empty their bladder beforehand, and they need to lay still. Remember to assess them for problems with claustrophobia so they can maybe get a sedative. Post-procedure, there are no radioactive precautions. The patient is not that radioactive, but you do need to encourage them to increase their fluids to flush out all the dye. All right, DEXA scanning is used to measure the amount of calcium in bones, which is an indicator of density, and it's usually done in the hip, heel, or spine. It's used to screen for osteoporosis or to diagnose the progression of osteoporosis. Currently, shockingly, there are not any real recommendations from the CDC or the other federal entities on screening. They just say that women should get screened at the age of 40 for a baseline, and then women over the age of 65 should be scanned, or women under the age of 65 who have increased risk for fractures. And I think the risk profile, from what I can read and find out, is the risk profile for increased risk for fractures includes loss of height, bone pain, other fractures, and being postmenopausal. So it's very vague, and the recommendations are very, very vague. Nursing implications. Pre-procedure, you just tell them about the procedure, and then you get them ready like you would for a normal x-ray where they remove their metal objects wherever they're getting it done. I think that if they're having their hip scan, you don't have to worry about wires and bras, or if they have a necklace on. Okay, it's not going to affect it, but you do need to make sure that they don't have any like rivets in their pockets if they're wearing jeans or something like that. Okay, post-procedure. Now here's where we can really look at the different levels of prevention. So DEXA screening or DEXA scanning is a secondary prevention. We're screening to see if there's a problem. That is secondary prevention because it's not going to prevent the problem from occurring. We're just screening to see if there is a problem. That's what a DEXA scan does. So if then the results come back and your patient does not have osteoporosis, then you engage in the primary prevention where you're teaching the patient how to prevent development of osteoporosis, and that includes weight-bearing exercises, taking calcium and vitamin D supplements, watching the medications that they're taking, and also some diet issues. Lots of sodas, lots of caffeinated beverages, that kind of thing can suck that calcium out of the bones. So they need to be careful about their intake of those kinds of drinks. They also need to make sure that they include calcium in their diet. While calcium supplements are great, remember we use nutrients from a regular digestion better than we do from supplements. So you need to talk to them increasing their calcium intake. And we'll talk about that more when we talk about the whole osteoporosis problem. Now, an EMG is electromyography and nerve conduction studies. And I've had this done. I had it done when I injured my neck, and it is probably one of the worst things that I've had to do for a diagnostic test ever. And let me explain how it's done, and then I'll explain why it was so bad. So what people who get an EMG done are having a problem with muscle weakness or nerve problem, like a neuropathy. And what they do is that they come in and they put the electrode on, and you can see that electrode right there, and they stimulate muscle contraction. And then they measure the muscle contraction through this very thin needle. And I will admit it's a very thin needle. It's a very long, thin needle. And they stick the needle into the muscle that they're trying to stimulate to contract, and they measure the contraction. And the needle acts as like a transducer to measure pressure or contractility. It can be used to diagnose neuromuscular disorders like ALS or muscular dystrophy, Guillain-Barré, diseases like that. Also peripheral nerve disorders like peripheral neuropathy, and also motor neuron disease like multiple sclerosis, where you're having a problem where the neurons are being destroyed. The myelin sheath is being destroyed. So on the motor neurons, so there's a decreased contractility because of decreased electrical nerve impulse. Now, the procedure is usually done at the bedside in an outpatient. I've already discussed that they put these thin needles in and they're recording the muscular response. I can tell you that when I had it done, I injured C6 and C7, and I had a radiculopathy, which is like a nerve problem down my left arm, and I was having problems with my hand grip and also difficulty lifting my arm up, and it was obvious muscle weakness, and I also had a lot of pain. And so that I went in to have this test done, and they probably stuck that needle in my arm. Now, it's the same needle because I'm the same person. They do scrub the area, but it's the same needle. I think I was probably stuck with this very thin needle between 30 and 50 times. And so, initially the sticks don't hurt that bad, but then when they keep doing it, it's incredible. The pain, I can't even describe how bad the pain was. But it wasn't like a big pain all at once. It was just this continuous sticking, and then also making my muscles, it was awful. So I don't want you to go tell your patients that, Miss Sutton said, my teacher said that this was the worst procedure she ever had, and it hurt, and I just don't know what to do for you. There's not a lot you can do except for tell them that this is what's going to happen, but don't, play up. Everybody feels pain differently. It may have been the worst pain I ever felt because of the problems I was already having with the radiculopathy. Okay, so everybody's going to be different. But you can't give pain meds or sedatives because that will cause problems with the results. Okay, so nursing implications, pre-procedure, you need to tell the patient what to expect. They need to stop their anticoagulants and muscle relaxants well before the procedure, and then you need to get consent. That's all pre-procedure. Now, post-procedure, you need to tell them that they're going to have some bruising and some pain, but if they have a lot of pain and a lot of swelling, they need to report that, and they can actually use ice in the areas to decrease the edema and decrease the pain. Of course, they can also take pain medication, but ice is actually really good for that because it decreases the inflammatory process right there. So that is the end of the diagnostic procedures. I'll move into musculoskeletal disorders in the next video.